Okay. Speak about SGLT2 inhibitor, the real game changer of the century. Why are we calling it the real game changer? See, diabetes is no more limited to just management of glycemia. Diabetes is now considered as a multi-system disease because of the complications associated with diabetes. And whenever we tend to treat diabetes, we need to protect the target organs like heart, kidney, and other organs which usually are affected. And when we wish to treat the patients beyond glycemia, SGLT2 inhibitors came into the story. So about a couple of decades back, researchers identified SGLT2 and its presence in proximal convoluted tubule. When these were inhibited, almost 90% of the glucose that was filtered went out, and that had a glycemic effect. And it benefited diabetes by glucosuria and energy loss. And that was independent of insulin. So this drug was found to be effective even in people having compromised beta cell function. Later on, as we understood more about its mechanism, through reduced glucose and sodium reabsorption in the nephrons, it led to decrease in intraglomerular pressure, thus protecting kidney. Besides, it improved myocardial energetics. So switching off fuel to ketone led to better energy utilization by heart. Ultimately, it started helping failing hearts also. So when we talk about glycemic control being done by SGLT2 inhibitors, it is modest. It's not 1.5 or 2%. It's hardly 0.5 to 7% or at most 1%. But other pleiotropic benefits like weight loss, decrease in blood pressure, decrease in uric acid, and renal cardiac benefits has added a lot of things in it. So over the time, when CVOT trials were mandated, evidences started coming in about its beneficial effects. Right in 2015, IMPAREG outcome trial showed that it led to decrease in CV death by around 38%. Canagliflozin in CANVAS trial did show beneficial effect of around 14% decrease in CV death, and DECLARE-TIMI trial showed reduction in hospitalization due to heart failure. And remember, these effects started coming in within days to weeks. So in a chronic disease where these things do happen over a longer duration of time, these beneficial effects started coming in within weeks. And when you talk about different trials, DAPA heart failure trial and IMPERA reduced trial showed its beneficial effect in heart failure with reduced ejection fraction. DELIVER trial did demonstrate its beneficial effect in heart failure with preserved ejection fraction. Once again, I would like to remind you that it was not dependent on only glycemic uncontrolled or glycemic effect. These effects were seen even in people who were non-diabetic. Moving ahead, renal protection by SGLT2 inhibitors has been demonstrated in CREDENCE trial by canagliflozin, then came DAPA-CKD, and EMPA kidney trial, and overall kidney outcome reduced by 30 to 40%. I have already told, by reducing hyperfiltration and inflammation, it protects kidney by decreasing the intraglomerular pressure. Now, once you are protecting heart, you are protecting kidney, there are many pleiotropic benefits. It also translates into decrease in all-cause mortality. That was seen almost, you can see, around 20% decrease all-cause mortality in clinical trials. Then comes question that, well, these things were demonstrated in randomized controlled trial. Are they replicating in real world also? Yes. Trials like CVD Real, EMPA-RISE, including more than 2 lakhs patients in post or real world studies, have confirmed that whatever trends those were seen in randomized controlled trial, like fewer hospital admissions because of heart failure, better survival and slower renal decline, they were demonstrated in real world trials also. So, well, my dear friend, in this century we have got a drug which is working in diabetes with a wonderful mechanism, having its protective effect on heart, kidney, pancreas, anti-inflammatory, natriuretic effects. But any drug which has got good efficacy comes with some caveat, and genital infection is really troublesome part. But let me tell you, proper education about genital hygiene has been able to help us in dealing with genital infections that are usually associated with is usually associated, I would say, in less than 10% or so in people who are on SGLT2 inhibitors. Somebody may argue that in their personal clinical experience, infection with genital infections are more with SGLT2 inhibitor, and I would say I don't differ here, but yes, they can be tackled with proper hygiene education and withdrawing drug for some time. Rare euglycemic diabetic ketoacidosis has been seen in patients undergoing surgery, acute illness, or heavy alcohol consumption. Similarly, dehydrations are some issues which are associated with it. So, well, these are some negative aspects, but when you see the benefits that it has, you will certainly find that there is a huge spectrum of people who would be benefited by SGLT2 inhibitors. Mostly type 2 diabetic patients with established CVD, heart failure, in entire range of ejection fraction, reduced and preserved ejection fraction, irrespective of diabetes, normoglycemia or non-diabetic or diabetic. Similarly, chronic kidney disease with or without diabetes, patients who are overweight or has metabolic risk, at all these places, this drug has been found to be beneficial. Early users with early results have given even more importance to use of this drug. And that's why you see the convergence of global consensus on use of SGLT2 inhibitor, starting from ADA, ESD, KDIGO, and even our RSSDI, all endorse SGLT2 inhibitor for cardiorenal protection, irrespective of HbA1c level. Dear friends, now SGLT2 inhibitor is the real game changer because it's not limited to diabetes. I have already told that even in absence of diabetes, it has got promising effect, established effect in heart failure, CKD. Further studies are being done to find out its beneficial effect in obesity, NAFLD, and even post-MI remodeling. Compared with GLP-1 receptor agonist, which is also coming up great in terms of beneficial effect on ASCVD and weight reduction, we can see that SGLT2 inhibitor is mostly beneficial in heart failure and renal protection, and rather than competing with each other, they do have complementary effect and they can be used together. However, there are barriers and challenges for its use, particularly in cost-sensitive Indian population. Thankfully, dapagliflozin and empagliflozin are off patent now and they can be used. The other barrier is fear of genital infection, euglycemic ketoacidosis. Probably adequate education amongst physicians, doctors, diabetologists and passing it to the patients is going to help us in tackling this. Indian real world experience has also been great. So dear friend, with such a wonderful molecule, we do have some promises for future also. We are trying to work on dual SGLT2 inhibitors like sotagliflozin, then combination therapy of SGLT2 inhibitors with GLP-1 receptor agonist, phenylalanine. So you may think of an era of polypill coming in where a single class of drug is trying to protect multiple organs. And that's why I say that this is the real game changer in the management of diabetes of this century. SGLT2 inhibitor has redefined what diabetes treatment means. It's not limited to only glycemic control. They protect heart, preserve kidney, reduce mortality and improve quality of life. Truly, not just a glucose lowering drug, but a real game changer of the century. So, dear friends, I would like to summarize once again. SGLT2 inhibitor is a game changer because it protects your heart, reduces heart failure, hospitalization and severe death. It protects your kidney, preserves kidney, lowers the risk of end-stage renal disease and renal decline, reduces mortality approximately 20% and gives improved quality of life. All these things are based on different studies and this is what transforms. So at the end, I would like to conclude